Good evening, everyone. Going to be doing Ask Me Anything tonight with Dr. Twyman, heart attack prevention expert. Hopefully a jet lag prevention survivor. So I was a little bit silent last week just because I was finally doing some international travel. Finally made it back to Italy, one of my favorite countries in the world. Spent a week there just touring wine country and the Italian countryside. The people were pleasant as always, and ate more pasta than I would eat in a year, essentially, in 1 week. So we'll give a few minutes for other people to log on, but tonight I'm going to answer some questions that people put in earlier today, so thank you for that. We'll answer those questions, and if you have any live ones, drop them in the comments below, and we'll answer them as we go. So, all right, guys. So let's see. So hopefully this pops up here. So question 1 is high ldl-p, which stands for LDL particle, a big risk factor for heart disease if the oxidized LDL and inflammation markers are low? It's a great question. So it is complicated in ways, but it really depends on what is your endothelial function. So the inner lining of your arteries tells the whole story. So when the endothelium gets damaged, then the LDL particles, the ApoB containing particles for the most part, have more access to the intima, the inner lining of the arteries, and inflammation, plaque formation is more likely than once you have endothelial dysfunction. But LDL particle number by itself can be a problem. So you can think of them as cars on the highway or boats in the on the rivers. The more that you have, the more risk that they interact with the walls of the artery and get retained in there. Now, if you have inflammation, the artery's endothelium is likely getting damaged much more rapidly. So, high LDL particle and high inflammation is, 1 + 1 = 3. It's synergistic. But just having a high LDL-p can be a problem as well. So it's one of those things, test, don't guess. So test your endothelial function with either a max pulse or an endopap. Look at the intimal thickness with a carotid intimal medial thickness test, or do a CT coronary calcium score to see if there's any hard, old calcified plaques in your arteries. And if the answer is yes on any of those, then the LDL particle number, is an issue, and you want that number to be lowered through lifestyle supplements and medications. Great question. All right, let's see if we can get. Welcome, everybody. Just doing Ask Me Anything. I did survive my jet lag from Italy, day 2 on the return, which isn't as bad as going east, but I think my body still thinks it's about 1 a.m. right now. All right. I got 2 questions on this one. This came out last week while I was traveling. This from the U.S. Preventive Task Force, asking about daily aspirin use. So it does kind of break down a little bit into, if you're over 60 and have already had a heart attack, stents, bypass surgery, stroke, you're high risk, you're going to buy an aspirin for secondary prevention. You're trying to not have another event. That's not what this one is talking about. This is more for primary prevention, so somebody who's never had an event. So if you're between 40 and 60, basically talk to your doctor about it. What are your risk of bleeding? If you had gastric ulcers in the past, uncontrollable hemorrhoidal bleeding, your risk of bleeding outweighs likely the benefit of reducing a stroke or heart attack on aspirin if you're between 40 and 60 without a prior event. If you're over 60, the benefits of bleeding, the risk of bleeding possibly outweighs that risk, the benefit of being on aspirin. So in other words, I would say that, if you've not had a heart attack, stroke, talk to your doctor about it. But one thing that they don't talk about in this task force guidelines is, what about patients who have subclinical atherosclerosis? So meaning they have plaque in their arteries, but they've not yet had a heart attack or stroke. So it's more of a gray zone where, if you consider somebody who's had a heart attack or stroke black and somebody who's had no events white, well, what about somebody with a high-risk CT coronary calcium score? What about somebody who has a thick intima and a vascular age 20 years older than their biologic age? What about somebody who has abnormal endothelial function? Those people are higher risk than this guideline would include. So people who have abnormal calcium score tests, especially if the calcium score is over 100, I would still go ahead and continue the aspirin unless there's a strong reason not to. But this is not medical advice to any particular person I'm talking to on this. This is just general advice. But if you have a high calcium score test, more likely than not, you're going to remain on the aspirin for the benefit. You just don't want the platelets clumping together if one of those plaques ruptures. All right. Oops. Okay. Next question here. And I answer this question, so just clicking on that. So it's the U.S. Preventive Task Force. So don't stop aspirin unless you talk to your doctor about it. Next one, I don't know any other options. So somebody's asking, how to get rid of a lipoma. So lipoma is just a generally benign fatty collection under the skin. It's usually sometimes like a marble or golf ball that you can kind of roll around under your skin. A lot of times on the back or the abdomen. If it's not painful, most of the time you just leave it alone. Most of them you can diagnose it by physical exam, but to really confirm it, they would need to either biopsy it or take it fully off. And if you take it fully off, that's the main treatment. So surgery is the main treatment option for it. There are some centers that will do liposuction for it to kind of suck the fat out of it. But in the extremely rare instance, there can be a malignant form of lipoma called a liposarcoma. Generally, they're going to be painful to touch to begin with, but you can't tell for sure unless you take a piece of it out of it. So I don't have any magic biohacking ways to get rid of them. I don't think photobiomodulation or anything like that's going to make these things go away. If you get up, end up having lipoma surgically removed, then I probably would use red light therapy or photobiomodulation to kind of heal up the scar tissue, and lower the inflammation in the area, but it by itself isn't going to reduce the lipoma. All right, this is a high-level quantum health, hacking, or I should say quantum health kind of question. So, do I think heart rate variability impacts how the crystalline structure of our exclusion zones form? So let me break that down for people who haven't been following the Quantum Health TV series. So, first off, what is heart rate variability? I've done prior talks on that, but heart rate variability is the beat to beat difference. So your heart rate should not always be 70, 70, 70. As you breathe in, your heart rate expands and contracts as you're stimulating the vagal nerve. When you're breathing in and out, your heart rate should go from 70 to 80, back down to 65, and the bigger the swings. So the better the heart is conditioned. Heart rate variability is a very sensitive marker for the amount of stress that the body is sensing at that time. It's one of the better markers to know if you're overtraining with exercise. That's also a good marker to say that if your heart rate variability is becoming abnormal compared to your baseline, you may be coming down with an infection. Recently I had a patient monitor their sleep with a Oura ring, and the heart rate variability was worsening, the heart rate was increasing, the temperature was increasing. And I told the patient, that's sometimes a particular sign that you may have COVID, go get checked out. Fortunately, they didn't have it, and it got better in a couple of weeks and such, but it was kind of an early warning sign something was going on. So, one of my favorite ways to kind of monitor heart rate variability, typically would be the Oura ring while sleeping. Also playing around a little bit more with the Whoop band. I don't always wear the Whoop band, but since I just got back from Italy, I'm going to try to monitor my heart rate variability to see how fast I can kind of get the jet lag over with and get the heart rate variability back to normal. So that's what heart rate variability is. Exclusion zone water. So the book to read about this would be Gerald Pollack. It's called The Fourth Phase of Water. Great book, written at a non-medical professional level, so anybody who has a little bit of basic science would be able to understand the context of the book. But basically, his lab and others have discovered that there is a fourth phase of water where the water is more gel-like and crystalline. How's that important to you? Well, your mitochondria make water. As they take foodstuffs in, water and carbon dioxide are made in addition to ATP, but the water can become crystalline, and there's positive and negative charge in the water, and that basically is a water battery. The water battery is mostly driven by UV and infrared light, and so that's why the importance of being outside in the sun, especially in the morning time for the red light, and then in the midday for the UV light to expand that exclusion zone. Honestly, I had to give the shout out to Carrie B. Wellness. I've done Instagram Live with her a week or two ago. She is an expert in exclusion zone water, so just go follow her page and you get a lot more information about what exclusion water is about. But I don't see any particular link that heart rate variability would actually directly improve in the exclusion zone. But I would surmise that if you had poor heart rate variability, meaning something bad in your environment is breaking it, so poor sleep, over-exercising, having an infection, you may be not making as much exclusion zone water. So those may be the times where you have lower HRV. You'd want to be spending more time, outside in the sun or using photobiomodulation to try to build up that exclusion zone. You also can use a sauna to do that part. All right, and then let's see. I think I got one other pre-written question. If you guys have any other ones, just drop them down in the comments and we'll answer them. So this is another really good question. I've not been asked this one before. Does the heart get impacted by LPS as much as the gut and liver? So LPS stands for lipopolysaccharides. Essentially, it's the outer coating to gram-negative bacteria, gram-negative rods in particular, so mostly E. coli and Salmonella. So the way that I kind of learned from some very wise professors about LPS was that it is a direct endothelial glycocalyx toxin, essentially. So earlier in one of my questions I talked about the endothelium. The endothelium is the inner lining of your arteries. It's 1 cell thick, and that coating would be about the surface area of 6 tennis courts if you took out all your endothelium in your arteries. So it's one of your largest secretory organs, mostly releasing nitric oxide from those cells. But overlying the endothelium is something called the it's called the EGX, so it's endothelial glycocalyx. It's like a gel coat. That exclusion zone water is actually very active in that area. It's negatively charged. So this endothelial covering called the glycocalyx, it's kind of like these little hair-like projections or cilia that protects the endothelium. And the glycocalyx gets damaged by inflammation, high sugar, high insulin, but the LPS definitely will damage them as well. And so if you have high levels of lipoprotein, I'll just call them LPSs. If you have high LPSs after a meal, those LPSs are damaging the glycocalyx, which then directly impacts your endothelial function. So the wise professor said, that atherosclerosis is a postprandial event. So the LPS damages the glycocalyx, the endothelium is exposed to what's floating through your bloodstream. Kind of ties into that person's question earlier about does high LDL particle count matter if you don't have inflammation? Yes, because if you have damaged endothelium, those particles transporting, mostly they're transporting energy. They're transporting triglycerides, phospholipids, fat-soluble vitamins, and there's just a little bit of cholesterol in it. But think of them as like little ferry boats. They stick to the damaged endothelium. It's like Velcro, and they're never going to get away. They get retained under the artery wall, and the immune system kicks up, starts attacking that stuff, and fires off the cascade that if you don't shut it down, you start building these little abscesses or pimples on the walls of the artery that over time potentially rupture, and that's what the heart attack or stroke's about. So the LPSs can have an effect on the endothelium, so indirectly it can impact the heart. I've not personally read anything or seen anything that the LPSs directly affect the myocardium, the actual heart cells themselves. It's much more that it would affect the endothelial cells. But great question there, Ryan. All right, so I think we got through the live questions, and I did see Carrie B logging on. So Carrie, welcome. I did answer a question earlier about heart rate variability and EZ. Wasn't quite sure of the linkage, but I would say that if you have poor heart rate variability, you're probably not making good EZ, and so you need more sunlight and more sauna or photobiomodulation to help build that up. All right, so I think we got a couple questions in here we'll go through. So somebody's saying, coming from the standpoint that HRV is essentially the frequency at which you resonate, and noting that it goes up and depending on emotional state. Good point. I just haven't seen anything about that per se. Trying to think of what would be a good way to actually try to even test that. Probably do something like cardiac coherence. Do heart math and see if you're getting high brain and heart coherence, and then you can probably do some physiologic testing, like a max pulse that would look at arterial elasticity. You could do nitric oxide testing. If all those levels are improving, that's usually a good sign that you're having good energy output from your mitochondria. So that's a possibility. All right, what else we got here? So I think somebody's asking a question about sodium. So salt consumption, how does it affect the heart and arterial health? And is there a recommended daily sodium level? That's a valid gauge. How to tell how much salt I'm consuming. Some foods taste way over salted. So salt consumption is an individual type of set point. So just saying everybody should be under 2 grams a day is not correct. Most people are actually probably underdoing their salt intake than necessarily overdoing it. And very few people are actually truly salt sensitive hypertensives. So my practice is heart attack stroke prevention. Blood pressure is one of the major 300 to 400 different things that are going to help damage the arteries. So I'm always checking blood pressure in people. But very few people, if they cut out their sodium, their blood pressure goes back to normal, and that's the only thing they do. Always worthwhile to try to cut back on added sodium, not oversalting foods, but most people are actually underdosing their sodium, and so I don't necessarily have everybody restricted unless they have classic heart failure and they're retaining fluid in their legs, or getting ascites or pulmonary edema. Then they're definitely going to have to kind of cut back on their sodium intake. But the average person, just monitor blood pressure and just essentially urine output. How hydrated are you? So if you're hydrated enough, your body will take care of all the sodium intake. All right. So somebody's asking a question. Understandably, caffeine seems to increase my quote stress as measured by my Garmin. Does caffeine have a negative impact here, or is it fine? Great question. So caffeine is metabolized a little bit differently in people. So 6 out of 10 people are going to be able to slow metabolizer of caffeine, where the caffeine is going to stick around a lot longer than the half-life of 6 hours. So a rough estimate is that about half the caffeine that you have in the morning time is going to be in your system going to bed. So if caffeine is affecting your sleep, either by duration or your heart rate variability is really off compared to what a normal one would be for you, potentially it is the caffeine load. I can just tell from personal experience that I am a fast metabolizer. I've had it checked. There is a SNP that you can get checked. It's usually on 23andMe, or you can ask your doctor to check it. That will look at your liver's ability to basically break down caffeine. But if your sleep is not optimal, so if you're using any type of sleep tracker and you're not getting, high restorative sleep, you have low deep sleep or low REM sleep, cut out the caffeine just early in the morning, or cut it out completely. If you don't have the genetic testing, your very old wives' tale would be just, if you could, basically pound a Mountain Dew and then go to sleep and not have any issues with your sleep in the morning, that you wake up the next day, then you could potentially get by with it. But if it's thrashing your sleep, you just need to cut it out. Caffeine is one of the bigger drivers of people's blood pressure issues, and I can also tell from recent personal experience, I've probably almost doubled my caffeine intake the past week, just because chilling in Italy, drinking the cafe, which is espresso in the U.S., and their cappuccinos, they're just completely way better than I can make. So I did probably stress my system doing that a little bit, but that's what you do every once in a while to see what happens. But if it's affecting your sleep, just dial it back. Someone's asking a question: are essential amino acids a good substitute for protein? Protein is just a collection of amino acids. So I guess the question would be: are branch chain amino acids a good substitute for whole protein? The short answer is no. Your body needs other amino acids in a complete protein. Most complete proteins are going to be more animal-based. Could you do it with plant-based? Yes, but typically the quantity is lower, so you're going to have to do more volume, and you potentially have to add more sources to get a complete protein through a plant-based means. And so maybe in that instance you might want to add a branched chain amino acid so you get a little bit more leucine in that situation. But by itself, it's not a good substitute. Your body needs more things than just the amino acids in a supplement. All right. And then I don't know exactly what measurement, but somebody says they hit 200 overnight HRV after San Pedro doing mescaline. So I don't know honestly what 200 is. I mean, is it the SDNN? Is it one of the other metrics of heart rate variability? 200 seems quite high, but it depends on what your baseline is. All right. And see, Jeremy just joined. Welcome, Jeremy. So hey, he's been doing a lot of training for a triathlon. Good luck with that if you haven't already started that. I just got back from Italy 2 days ago. I'm almost through my jet lag mitigation protocol, so I'm finally getting back on social media and catching up with people. So. All right. I think I've answered everybody's questions so far. So if any other ones are popping up, I'll answer them. I'll stay on a few more minutes. I'll get back to my routine Monday night 6 o'clock talks. I have one coming up in the future with another photomodulation owner of a company. We'll talk about dosing of photomodulation and how to actually, look at a panel to know if they have quality metrics. Can you tell what the wavelengths are just by looking at their website? What is their radiance? Essentially the intensity of the light. So you want to know, are you basically buying a flashlight or a spotlight? Because the photons, it matters on the power density and such. So we'll try to do that in another week, and then if anybody has another topic that they want me to hit upon, I'll just shoot in comments or send me a DM. Question, different topic. When do I typically work out? Generally try to do it in the afternoons. That's when your circadian rhythm is optimized to work out, especially for muscle strength. But there's a great app that I've used in the past called the Circadian app. You just plug in where you're physically located, and it'll tell you, what time it is generally best to work out for you. I understand the reasons why people would, and I used to do a lot of morning workouts, I still pretty much do every day walk at sunrise. That's just one of the best ways to kind of start the day, clear the mind, and get ready for the day. So I don't necessarily consider a, brisk walk in the morning exercise for myself, but doing more interval training or strength training, I generally do that in the afternoon. If you're gonna do morning exercise, highly encouraged to be doing it outside. So your circadian rhythms are set. You don't want to be, pounding out, heavy weights at 5 o'clock in the morning under a bunch of blue light. All right. Somebody's asking another photomodulation question. So, can you do it twice a day if they want to hit different areas? Yeah, that's fine. You can do twice a day to any area, that you want to do. Generally, it's more the duration is the issue. So, people are staying in the 10 to 20 minute sessions per whatever treatment. Typically for musculoskeletal benefits, once a day is generally enough, but if there's an acute injury, twice a day might be a little bit more beneficial. But generally you're not going to overdo it as long as it's not too long of a session. Yes, my trip to Italy was fantastic. That's one of my biggest hobbies is international travel, just to be in different cultures, see a bunch of history, and eat the good food. So it was outstanding. So looking forward to getting back to Europe again, hopefully sometime next spring. Question, what is a good heart rate variability on the Oura ring? Someone said it should be close to your age. That's probably a rough estimate, but it really depends on what is a good heart rate variability for you, because each of the devices that measure heart rate variability do it a little bit differently. And so, like a good biohacker, I would frequently look at wearing both the Oura ring and the Whoop band at the same time and put them in airplane mode so I'm not getting exposed to the Bluetooth and such. I do know the risk of putting these things on myself, so that's why I don't wear them all day long. But most of the time the heart rate variabilities are nowhere near each other, and wearing them on the same arm or other arm doesn't make a difference. So mostly just look at whatever the number is and look at, is it changing over time? I would classify my heart rate variability generally, quote, low if I was comparing myself to others, but it's been chronically the way it is for years. And, I'm definitely not overtraining or ill or anything like that. So I think that's just the way I'm wired together at this point. But it's been quite a while since I've done a talk on heart rate variability, so I'll go through some of my files, and I'll start pulling up some of the metrics on that, and I'll do a talk about that in probably, let's give it 2 or 3 weeks. All right. All right, guys. Well, we're getting about the bottom of the hour. I'll let you get back to dinner. Hopefully you end it soon. And we'll meet up again next Monday, 6 o'clock. We'll try to see if we can do a photomodulation one. If not, I'll put together something cardiovascular specific, and I'll shoot in my stories over the next few days. So I'll start sharing a little bit more of my pictures of Italy now that I'm back. So guys, have a great week, and we'll see you next time.